This will be Chapter 29, Bowel Needs. Again, you will complete your Evolve review questions at the end of this. Watch any skills videos on your Evolve account. Go to your NHA Module 1 and review this section. And also go to Blackboard and look for any YouTube videos that I have put on there. All right, let's get started. All right, so bowel elimination is the excretion of waste from the GI tract or the gastrointestinal system. Defecation is the process of excreting feces from the rectum through the anus. It's called a bowel movement or a BM. You'll see it. Okay. Of course, we will assist patients and residents in meeting their needs. We always want to factor in their privacy, their own habits, their age, their diet, if they are exercising or active at all, their fluid intake, and any medications that they're on. So, again, everybody is different, so the time and frequency of BMs vary. So, we need to know about stool. Stools normally are brown, are soft, formed, moist, and shaped like the rectum, have a normal odor caused by bacterial action in the intestines. Bleeding in the stomach and the small intestines cause black or tarry stools. So remember that. In the stomach or small intestines, if there's bleeding, you'll see a black or a tarry stool. Bleeding in the lower colon and rectum causes more of a red-colored stool. Okay? Some foods, diseases, and infection can change the color of stools, and certain foods, of course, and medications can change the odor. So here's a chart on different colors, okay? Excuse me. So we're looking more for this brown color, and we'll go through why you might see some of these others. Again, this black would be higher up bleed. This bright red would be a lower bleed, okay? Okay. When we observe the stool and chart on it or report to the nurse what it looks like, we want to know the color, the amount, the consistency. Is there any blood or mucus, the odor, the shape, and how often they're going, and if they're complaining of pain or discomfort when they have a bowel movement. You want to report to the nurse immediately any liquid stools, which is diarrhea, any hard pebble-like stools, which would show that it's constipation. No stool for more than 3 days unless they're NPO for several days. Any unusual quantity of stool or frequency of bowel movements. Any visible blood in the stool. Again, any tarry-looking stool, which is that dark red or black in color. Any visible pus or fat in the stool. Any objects. So children like to eat toys and other things, so you might find a dime or a small toy in their stool. So we need to make sure we report any of that. And again, here are some of the shapes. So this formed with lump stool is more constipation, okay? And this is watery. Okay, this is loose unformed. It should be in the form of what your rectum is, okay? All right, you remove the bedpan after the patient has a BM. Which of the following characteristics should you report to the nurse? All right, we're going to report a liquid stool because that is not normal. All the other ones are normal. All right, factors affecting bowel elimination. Normal, regular elimination is the goal, of course. Factors affecting stool frequency, consistency, color, and odor could be privacy. Some people, if they're in a room with a roommate and they have to use a bedpan, they just can't do that. Or if you have to sit in the bathroom with them, they can't. Privacy is a big issue. Their own habits. You're asking somebody to go in the middle of the day and they're used to going in the morning. Maybe their diet has changed. They either have high fiber diets, which have made them have looser stools, or they have not had enough fiber in their diet and they're constipated, that kind of thing. Fluids. A lack of fluids can cause constipation. A lack of activity can cause constipation. Medications can change our bowel elimination frequencies and etc. Aging. or if the person has hemorrhoids, can interfere with normal elimination. Constipation is the passage of hard, dry stool. It occurs when peristalsis, which is the movement through the intestines, slows down. Common causes are low fiber diets, ignoring the urge. You know, they had to go, but nobody came to take them to the bathroom. Hours have passed, and now the urgency has gone away. Maybe decreased fluid intake. Maybe they're used to exercising, and now they're inactive and they can't go. Medications, aging, and certain diseases. Okay. The doctor may have to order stool softeners, laxatives, suppositories, or enemas. Okay. Fecal impaction is prolonged retention and buildup of feces in the rectum. They're unable to have a BM, and we need to make sure we let the nurse know that signs and symptoms of this right away. Feces are hard or putty-like. It could result if the constipation is not resolved. Symptoms include abdominal discomfort, abdominal swelling, nausea, cramping, rectal pain, low appetite, confusion, or even fever. All right, hemorrhoids can lead to elimination problems, true or false? True. Good. What does hard, pebble-like stool indicate? Constipation. So the nurse will have to check digitally using her finger to check for an impaction. With this, she would be doing gloved hands and using a lubricant to see if she can feel the hard mass. Usually it is in the lower rectum, but sometimes higher in the colon and out of reach. A lot of times this will increase the urge to have a BM for that patient. The doctor may also have prescribed medication, suppositories, or enemas to remove that impaction. Sometimes the impaction can be removed with with digital removal. Other times we may have to do it like I said, a suppository or an enema. Checking for and removing impactions can be very dangerous. We talked about this before. There's a vagus nerve that can be stimulated, which can slow down that heart rate, which could be dangerous for folks. All right, another problem is diarrhea, which is frequent passage of liquid stools. Feces moves through the intestines rapidly. Some people with diarrhea cannot get to the bathroom in time. They may have severe cramping, nausea, and vomiting. Medications or diet are ordered to reduce peristalsis. So what's happening with this person, instead of peristalsis slowing down, it's increased, okay? We would assist with elimination promptly, dispose of stool promptly, and give good skin care because we do not want to risk the skin breakdown or pressure ulcers, okay? Also, we need to remember that fluid loss through diarrhea must be replaced because they can become dehydrated. And dehydration, if you remember, is the excessive loss of water from tissues. So our blood pressure would decrease, pulse would increase, respirations are also increased when we have dehydration. Death can occur. So the nurse would probably be administering fluids by a doctor's order of IV fluids, okay? Which is true. All right, let's see what you came up with. So yes, stools are normally brown, soft, and formed. Fecal incontinence is the inability to control the passage of feces and gas through the anus. Causes could be intestinal diseases, nervous system diseases. Fecal impaction can cause this, diarrhea, medications, aging, mental health, etc. So all these can contribute to this. Fecal incontinence affects the person emotionally. Again, they're going to be embarrassed and humiliated, so we need to comfort them as much as possible. They may need bowel training. They may need help with elimination right after meals. Incontinence products to keep them, their garments and their bedding clean, and definitely need good skincare so we don't have any problems with wounds. Flatulence is an excessive formation of gas or air in the stomach and intestines. It's passed through the anus, and it's called flatus. Includes swallowing of air can cause this when we're eating or drinking, and then bacterial action in the intestines can actually increase it. Just eating foods that are gas forming, person may be constipated. Also, after having surgery, this is a big problem. Medications like pain medications will decrease peristalsis and increase flatulence. Okay. Signs and symptoms include person's abdominal cramping or pain. They might become short of breath. You'll see their belly swelling, and they complain of being bloated. If the flatulence is not expelled, the intestines are going to distend. Things that might help are exercise. So remember, if that person's bedridden, you can do the range of motion exercises that we were taught. That will help. Walking the person, moving the person around in bed, and also that left side lying position. Remember that Sims position? This will help. Also, there are medications and enemas that could also help that the doctor would order. All right, flatulence can be caused by which? All the above: swallowing too much air, constipation, and abdominal surgery. Bowel training. So fecal impaction, constipation, and incontinence are prevented when there's regular bowel training. The goal is to control bowel movements and develop a regular pattern. So things that would be included in this are high fiber diets, increased fluid, warm fluids like coffee in the morning, activity, and privacy. The prolonged retention and buildup of feces in the rectum is called fecal impaction. Bowel training is aimed at control and regular elimination. Suppository is a cone-shaped solid drug that is inserted into the body opening, and it melts at body temperature. It is inserted into the rectum along the rectum wall and not into the stool directly. So when it's inserted, we would insert it along the wall and not straight into the stool. Usually a bowel movement will occur about 30 minutes later. The doctor will order this to stimulate a BM for constipation, fecal impactions, or bowel training. And here's an example of how to do it. Of course, this left one, they're trying to put it right through the stool. We want to have it put into the side along the wall. Okay? Your state and agency allow you to insert a rectal suppository. You insert a suppository, how? And I just gave you that answer. So some states and agencies will allow you to do that. We will practice on how to do that along the rectal wall. Again, I want you to watch the skills videos on giving an enema. An enema is introducing fluid into the rectum and lower colon. Doctors will order to remove feces, relieve constipation, fecal impaction, or flatulence. It cleans the bowel of feces before certain surgeries and diagnostic tests also. A doctor may order the enema solution. There's different types, so he'll let us know which kind we are going to use. And remember, I've always said that the patient will be in Sims position to administer it, and we would insert the tube 2 to 4 inches. The solution depends on what kind of problem the person's having. So let's break it down. Tap water enema is obtained from the faucet. A saline enema is a solution of salt and water. A soap suds enema, or an SSE, is a solution of cast-style soap and water. A small volume enema is commercially prepared. Oil retention enema is mineral, olive, or cottonseed oil. And of course, there's other ones. Nurses would give any kind of enema that contains medications. Giving an enema, the person's in Sims position. The enema bag hangs from an IV pole. The bag is about 12 inches above the anus and 18 inches above the mattress. Cleansing enemas. Why do we use them? We're going to clean the bowel of feces and flatulence. It relieves constipation and a fecal impaction. They're needed before certain surgeries. Cleansing enemas take effect in about 10 to 20 minutes. The doctor may order an enema to be given until the liquid that's coming out of the rectum is clear. Tap water enemas can be dangerous. Only one tap water enema is given, and you never repeat that one. Okay? A saline enema solution is similar to body fluid and is used with children. And a soap suds enema irritates the bowel mucus lining. So remember that about that one. So it can be very irritating to the bowel. Small volume enemas irritate and distend the rectum, often ordered for constipation, also ordered when the bowel does not need complete cleansing. Okay? When giving the small volume enema, do not release pressure on the bottle or the solution will drain from the rectum back into the bottle. Also, you will start putting air in there if you do that. So I'll show you how to roll it up and make sure that there's continuous pressure until the solution is done. And then without letting go of the rolled up bottle, you're going to take it out. Okay? You want that person to retain that enema as long as they can so that until they have the urge to have a BM. An oil retention enema relieves constipation and those fecal impactions. So it kind of lubricates the rectum, and they're commercially prepared most often, and it's retained anywhere from 30 to 60 minutes or longer. I can't imagine having an enema solution in me for 3 hours, but which cleansing enema is used in children? Do you guys remember? Saline, because it's most like our own bodies. A small volume enema is retained for how long? Until the urge to have a BM is felt. The small volume enema tip, you've seen these probably in drugstores, is inserted 2 inches into the rectum. This person is in Sims position, and there is a chuck underneath them. All right, the math of giving a cleansing enema. Take a picture of this slide, please. Okay, so the nurse is going to tell you the amount to give in a certain amount of time. To calculate the amount to give per minute, you're going to divide the total in milliliters by the time in minutes. Okay, for example, they want 750 milliliters given in 15 minutes. Okay? So that means if you divide that, it's going to be 50 milliliters per minute. You're going to note the start time and check the amount at least each minute. Make sure it's flowing the right way. At 1 minute, for instance, the solution should be at 700 milliliters. At 2 minutes, the solution should be at 650 milliliters. Hopefully that makes sense to you. Okay, I'll give you one more second to take a picture. All right, which is used for a cleansing enema? Tap water, saline, or soap suds enema. Okay. Try to give the enema as quickly as possible to eliminate discomfort to the patient. True or false? That's going to be false. You don't want to do it quickly. You're going to cause abdominal cramping. You want to do it steady and slow. Okay. In adults, the enema tube is inserted how many? What do you think? 2 to 4 inches. Okay. All right, talking about ostomy care. So sometimes part of the intestine is removed surgically because of cancer, bowel disease, or trauma, and an ostomy is sometimes necessary. It's a surgically created opening for the elimination of body waste, and there will be a stoma, and the person would wear a pouch to collect their stool and their flatulence. Okay? A colostomy is where a part of the colon is brought out onto the abdominal wall and a stoma is made. That's where your feces will pass through instead of the anus. Okay? It's surgically created opening between the colon and abdominal wall, and with a permanent colostomy, the diseased part of the colon is removed. A temporary colostomy gives the diseased or injured bowel time to heal. After healing, the surgery is done to reconnect the bowel. Okay? The colostomy site depends on the site of the disease or injury of the intestines. Okay? An ileostomy is surgically created opening between the ileum, which is the small intestines, and the abdominal wall. This stool is going to be more liquid, and it drains constantly from the ileostomy. Okay? Part of the ileum is brought out onto the abdominal wall, and again, the stoma is made. The entire colon is removed with this. Feces in the small intestine contain digestive juices that are very irritating to the skin, so we have to be right on top of this. Okay? Ostomy pouches. Okay, so the pouch has an adhesive backing applied to the skin. Some are pre-cut, while others are not. Okay, so if they are not pre-cut, remember this. It's very, very important for your testing. Require cutting an opening 1/16 of an inch larger than the stoma. Okay, so you're going to cut the opening 1/16 inch larger than the stoma. Sometimes pouches are secured to an ostomy belt. Many pouches have a drain at the bottom that closes with like a clip or a clamp or some kind of wire clamp. Okay, the drain is open to empty the pouch. The pouch is emptied when stools are present. It is open when it balloons or bulges with flatulence or gas. And then I'm going to wipe the drain with toilet tissue before you close it. Okay? Now, the pouch is changed. So I'm talking about the whole pouch. It's changed every 3 to 7 days and when it leaks. Okay? So there's a difference between emptying the pouch and changing the pouch. Odors are prevented by performing good hygiene, emptying the pouch, avoiding gas-forming foods, and putting deodorants into the pouch. So there's a special little tablet that a lot of times will come with the pouches to put in to prevent it from smelling. Okay? Do not flush pouches down the toilet. A person can wear normal clothes. However, tight garments can prevent feces from entering the pouch. So you want to make sure the person's not wearing real tight clothes. And bulging from the stool and the flatulence can also be seen if they're wearing tight clothes. Okay? Showers and baths are delayed for 1 to 2 hours after applying the new pouch so that the adhesive can seal to the skin. Here's an example. So the ostomy pouch is secured, and on this instance, this person is emptying theirs directly into the toilet. Okay? Some key points on ostomy care. The PCT should hold the patient's skin so that it is taut and peel off the ostomy appliance from the top while gently pushing the skin away from the skin barrier portion of the appliance. You should gently wipe away any feces on and around the stoma with toilet paper. Antiseptic wipes, remember, are too harsh for the stoma and the skin around it, so it's going to burn and not be good for it. The PCT should press the wafer against the patient's skin for about 1 to 2 minutes to ensure a good seal when we're replacing it. And the PCT should wash the skin around the stoma with warm water, then pat the skin dry. Okay, question for you. You're assisting a nurse to replace a patient's ileostomy pouch for the first time following surgery. After cutting the skin protective wafer, the PCT should expect the opening to have which of the following characteristics? Let's see if you remember what I told you. The opening is 1/16 inch larger than the stoma. Okay, so you're replacing a colostomy appliance for a patient. Which of the following actions should you take? That's right. We're going to wash the skin around the stoma with just nice warm water. All right, you're reviewing the plan of care for their patient with an ostomy. Which care measure should you question? So you reviewed the care plan and you're thinking, something's not quite right. Which one of these would be wrong? Right. If we change those pouches every day, now of course there are times where we might have to, but if we change them every day, we're going to really irritate the skin. Okay? An ostomy pouch is usually emptied. How often? When there is stool present. Okay? An ileostomy drains what kind of substance? Now remember that ileostomy is lower into the small intestines. So the lower it is, the more semi-liquid stool we're going to see. Okay? All right, again, this is the end of this one. I want you to go and complete your review questions for this chapter. Watch your skills videos, and again, go to NHA, look up Module 1, and go to Blackboard and watch any of my YouTube videos that I have presented on there. All right.